So we're going to change up the agenda a little bit. I'm going to give the presentation on DRG simulation, and then Dr. Mehta is going to do the presentation in the lab, and then we're all going to get up, put on our T-shirts that are in front of you, and do a photo out there, and then we'll go to lunch. So we'll try to make up some time by consolidating this way. All right, raise your hand if you know what dorsal root ganglion stimulation is. How many of you have done dorsal root ganglion stimulation? Okay, about a third of the audience outside of the faculty. Well, this is one of my favorite procedures in the whole world, frankly, because it's really focusing on a different neural target that has a huge impact on many focal pain syndromes. Complex regional pain syndrome, when I was a fellow, was like the HIV/AIDS, the cancer of pain, right? Like so difficult to overcome with all the things we had. You threw medications at it. You did sympathetic blockade. You did all the rehab and physical therapy, guided imagery, graded motor imagery, all this, everything. And then nothing really worked. Maybe you got some temporary relief, but then patients came back. Or you did spinal cord stimulation and they got 50% relief, which was a success, but wasn't as good as where the patient really wanted to go. This therapy takes CRPS to a cure rate. I've seen 100% relief. I've seen patients' symptoms literally go away in the PACU. This has to be the de facto therapy for CRPS. It is crazy to think of anything else, frankly, based on the evidence that we have. So it's a relatively old technology in our world. FDA approved in 2016. We're working on innovation. It is probably one of the most challenging procedures that we have in interventional spine, to be frank. There's a lot of art to it, and Dr. Mehta is going to show us that. So these are the patients you're looking for from a diagnosis standpoint. So CRPS, as I've already mentioned, you should be thinking about this therapy for these patients. Not to say it's wrong to do everything else, but if you look at the overall evidence basis and management of CRPS, everything is pretty terrible. Right? There's one international paper out of Germany that looked at every single medication, and the only thing that showed some positive benefit was a topical DMSO. That's it. Gabapentinoids, even though they're prescribed for every single one of these patients, doesn't really work. The NNH is lower than the NNT for gabapentinoids and CRPS. Opioids certainly are contraindicated, I feel, for this because you're going to increase their hyperalgesia. Lumbar sympathetic blocks, stellate ganglion blocks, great, but temporary. So really, this gives you the best sustained therapy. Where I like to use this as well is in persistent post-surgical pain syndromes. So patients who are after arthroplasty, after thoracotomy, after sternotomy, after ilioinguinal hernia repair, all of those persistent post-surgical pain syndromes, ICD-11 will have those persistent post-surgical pain codes. And then peripheral neuropathies of all types, whether that's diabetic, whether it's chemotherapy, whether it's idiopathic. That's really where I like to use DRG stimulation. In order to do this procedure, you have to go through quite a bit of training for it. So currently the only company that has it for FDA clearance approval is Abbott. You have to go through a course. It's 2 days. It's indicated for T10 and below through S2. And as I mentioned, it was approved in 2016. You really want to think about this for focal pain syndrome. So we use spinal cord or dorsal column stimulation for pain of the trunk and limbs or the entire arm or neck. But if you have a focal pain syndrome, for example, of the foot, right? I mentioned peripheral neuropathy or CRPS of the ankle or something along those lines, DRG stimulation can really go to attack and focus on those specific areas. So the DRG itself is this bulbous structure in the paraspinal tissue. It is responsible. It is the cell body of the somatosensory afferents coming from the periphery. So basically, the cell body of every single nerve going out to your periphery comes through the DRG. It has a unique pseudopolar T-junction where basically a neuron comes in, up to the cell body and back down. The mechanism of action theory is that DRG stimulation provides a new filtration effect on nociceptive input. And that's why we see the improvement in symptoms. This is the Coyne-Hogan cryomicrotome paper looking at the epidural space in the green and the dye, and how we're able to get to the DRG using the epidural space as a conduit. The epidural space for most other physicians and surgeons is in the way. For interventional pain, this is our conduit, our river. It was meant for us. It's a very special thing to have an epidural space, and that's how we can get our leads to track out over the DRG. Looking at a parasagittal view here, you can see where the DRG hangs in the neuroforamen, basically in the posterior superior aspect of the neuroforamen. So that's really what you're looking for under AP and lateral fluoroscopy. Other things to point out, in the neuroforamen, you have a number of ligaments that suspend the nerve root in the DRG. That's actually what you feel every time you do a transforaminal epidural steroid injection. When you feel that increased resistance and then release, you're actually going through these neuroforaminal ligaments or intraforaminal ligaments. Really important to understand that. As Dr. Mehta will show you, when you pop out with the sheath, you'll feel this release. And that's actually really stimulating, because as you try to poke out with the sheath, it's going to stretch sort of the strings of a tennis racket and create tension on the DRG and nerve root. That can lead to some paresthesia, and in some situations, dysesthesia. And we'll talk about how we walk through that. This is what we're looking for. This is a radiograph, but nonetheless, it gives you an idea of where the DRG sits. As you go more caudal, the DRG is a little bit more lateral. So for L5, for example, you may have basically 3 electrodes more lateral, whereas in general, you want to have 2 electrodes more lateral to the midpoint of the pedicle, going up from L1 through 3. This is what your hardware looks like. So you use a 14-gauge TUI like you would for dorsal column stimulation. You have 2 curved sheaths, as you can see here, with 2 different curves, large and small. You have a stylet, which is the wire that goes inside the lead to give some rigidity. And then you have the lead itself, which is a quattrode. The diameter of the lead is 1 millimeter. That's juxtaposed to the spinal cord or dorsal column stimulation lead, which is 1.3 millimeters in diameter. So I call this the capellini of pasta. And then dorsal column stimulators are spaghetti, right? It's a little thicker pasta noodle. Positioning is everything, particularly for this procedure. If you do not position right, you will struggle, and we've seen people struggle. You can be sitting in the OR for hours if you just don't get this right. So make sure you remove that lumbar lordosis if you're going in the lumbar spine. And these are angles of approach. Dr. Mehta is going to go through this. So for example, if we're aiming for the T12 DRG on the right, we're going to be entering at that 12-1 space. We choose a point. I basically draw a line between the 12 pedicle through that midline of the intralaminar space and then down. And then depending on how big the patient is, so if the patient's 80 pounds, I'll start here. If the patient's 400 pounds, I'll start here. But it's this line that determines your trajectory, right? And you want to be at an angle, if you look in a lateral view, coming in about 30 degrees off the horizon. So that's the key point here. And so if you're going to do L5, it's the same idea. L5 pedicle through that L5S1 intralaminar space and out. You'll notice that the angle starts to increase in laterality as you go more caudal. And that's just showing you here. So L4 and L5, you can see you're coming in at a wider angle to get to those pedicles. But it's the same concept. There's nothing different whether you're at T10 or L5. You're really just following, where is the pedicle? Where is the midpoint of my interlaminar space? Where do I want to start depending on the girth of the patient? So this just shows you the sheath and lead together. We'll show you this in the lab tomorrow when we're all hands-on. But basically, you can see here the TUI engages. You're in the epidural space. You have to enter right at the midline. You do not, if you're too far contralateral, you don't have enough space to make your tension relief loops. If you're too far ipsilateral, you have to overcome the curvature of the dura, and that is very challenging with this procedure. So you really want to end up in the epidural space right at midline. Then we take that curved sheath and we bounce it basically off the pedicle, as you can see here, fluoroscopically. The sheath tip is this little radiopaque mark right there. These are the 4 electrodes. And you can see here, what Dr. Mehta will show us in just a moment is that he unscrews this and then retracts the sheath while leaving the lead in place. So basically, the sheath and needle are the Uber drivers. They take the passenger to its location, drop off the passenger, which is the lead, retract the sheath, okay? Now the fun part, making the tension relief loops, okay? This is basically the anchoring aspect of this procedure, as opposed to actually putting an anchor in sutures as you would with dorsal column leads. So when we first taught people how to do this, we just talked about doing one, cephalad loop. But now what we're really looking for are M's and W's, having 3 inflection points. Because if you think about it, it's like a spring. The more turns of the spring you have, the more mechanical energy you can put into the spring. Same idea here. So rather than having 2 inflection points, we encourage 3. And so therefore, if the patient starts moving, twisting, or whatever else, the energy now springs in the epidural space rather than forcing the lead or the electrodes to move out of the neuroforamen. So this just shows you step by step. First, that cephalad loop. Then what we do is we turn the sheath, the needle and the sheath out to the 3 o'clock or 4 o'clock position. You can see the sheath is now aiming to the right. Then we'll feed the lead so it creates that caudal loop, as you can see here. And then again, retract sheath. If we want to, we can add another loop out this way to make an M or a W. If you look at a lateral, you'll see the Cheerios. That's where we give each other high fives. That's great because that means these electrodes are facing perfectly out towards you. So these are just some of my pictures from some of my cases, just showing you bilateral placement. Here the lateral view shows us we're behind the posterior border of the vertebral body. That ensures you're at the DRG, right? The dorsal root ganglion. And this is just showing you some thoracic pictures of some cases. Lighting's not perfect, but you can see here. Same idea. There are the Cheerios looking right at us. Nice electrode from the EKG. This shows you sacral placement. So this was a patient who had severe pelvic pain, hadn't had sex in like 30 plus years, couldn't wear underwear because of allodynia. But after her DRG implant, she's having sex and wearing pants, underwear, you name it, riding motorcycles. And so this was a great case, one of my first cases. You can see here, this is an extrasacral loop. This is something that I've been doing if I can't get my loops within the sacral epidural space. Dr. Mehta has also been doing this. We call it the sloop or the extrasacral loop technique. So with that, I think we can turn it over to Dr. Mehta in the lab. Can you hear us, Pankaj? Well, while we transition, are there any questions about DRG simulation? Doug, microphone.
Just to clarify, I love the sloop. Just explain to them, if you would, why that's outside the epidural space rather than in at this level.
Yeah, thank you. So as I mentioned, we try to create our tension relief loops within the epidural space. At S1, that's pretty feasible. There's a decent epidural space, as you can see here. But as you go more caudal to S2, S3, this is off-label, frankly, but nonetheless, I've even done S4. There's really very little epidural space, right? So that bony canal narrows, but you need the tension relief loops. So what do? We go to the space of Naidu, which is this fake space on the posterior aspect of the sacrum, where I can shove in the lead. And what that does, again, it allows the patient to move without creating any movement of the lead. So I always try to get epidural. Like sometimes I can do it at S2, but the percentages are like 50% for me personally, where I have to go extrasacral. And it's a very easy technique. We take the sheath, we run it along the posterior aspect of the sacrum, feed the lead, retract stylet, and you can go up and down with that if you want. Thanks, Doug. Does that answer okay? All right. Yes.
So if it's a foot issue, you're always going to do L5?
And S1.
And S1?
Yeah.
Too. Okay.
Yeah. So you can be specific. If it's bottom of the foot only, S1. If it's both the top and the bottom, L5 and S1. Or if it's just the top, you could do L5. For peripheral neuropathies, as you know, they generally ascend, right? So I always start with S1. And what's really, one of my criticisms of how Abbott has taught us to do this procedure, we always focused on T10 through L5, and S1 was sort of an afterthought, or S2 was an afterthought. S1 is one of the easiest DRG placements you can possibly do. It takes 10 minutes to do bilateral S1 lead placement. It is as long as you become accustomed to it, it's really straightforward. there's so many people with peripheral neuropathy foot pain that if you can drop these 2 leads, you're not at risk of dural puncture, when you're that far lateral, if that's what you're afraid of. I think we really need to do a better job of making that more normal, more standard. So I'd strongly encourage you to learn how to do the technique. It's not that hard. And it
10 pounds less.
hey, buddy. Really straightforward and easy to do it, and it can really make a difference for patients getting off their medications. All right, you're back. He's on.
All right.
All right, Pankaj, take it away.
All right, Ramo, thank you. Well, for the interest of time, what I did was, if you look at the cadaver, I've got the needle placed in. And if you look what Ramo was talking about, even till date, I make my trajectory. So contralateral to where I'm going. You can see here, if Ramo, you can point out, you start off and the skin entry is about a vertebral body lower. And then you get into the interspine and the interlaminar space. You want to be a little bit in the upper part of the space, right below the spinous process. And the key step here is to have the needle placed perfectly midline and also in the higher part of the space below the spinous process, and kind of follow the trajectory which you have mapped out, which Ramo talked about, to go towards your destination, which is the contralateral foraminal space, in this case, the right L4. So the needle is in, and you've got a loss of resistance. And so there's 2 ways to do this. The sheath, the kit which comes with your rep will give you is pre-packaged with a sheath or the delivery system, and it's got a lead and it's got a guide wire in it. Now, some people would put the lead in the sheath and then advance the delivery system, which is the sheath. I use the word driver, and to basically park the electrodes and the foraminal space over your DRG. I use the guide wire. So I'll take the lead out and I'll put the guide wire. The key here is to remember that when you put the guide wire in there, the guide wire protrudes out, if you guys can see here, about 1 millimeter or 2 beyond the curvature of the sheath. The sheath is curved for a reason, because as you follow the straight trajectory and reach the doorsteps of the foramen, it takes a parabolic curve into the foramen where your DRG is parked. So you basically stabilize your needle, hold the sheath at the tip, and go ahead. If you look at this sheath or the driver, as I will refer to, there's got two white marks in it. So as soon as the first white mark gets in, you know that you're out into the epidural space. So I'm going to take an X-ray here, and all I'm doing is following that trajectory towards that right-sided L4 dorsal root ganglion. And so sometimes you may have to do a quick short run of live fluoroscopy. And as soon as you enter, I don't know if you guys saw that, there was a gentle pop which you noticed on that X-ray, and something which I felt, which tells me that I'm now through the intraforaminal ligaments. Ramo described that diagram very well, and I think one of the key things here is to remember that there are 2 layers of the intraforaminal ligaments, the inter and the intraforaminal ligaments. Sometimes you feel the first pop, but that's probably not enough. And as you drive this delivery system carefully, you'll find that you basically get the first pop and then the second resistance, which is the second layer of the intraforaminal ligaments. So it's important to actually kind of go a little bit further in gently so you can feel that second pop. So I'm going to basically undo, since my sheath or my driver is at the on top of the DRG underneath the inferior pole of that pedicle. So what I'm going to do is I'm going to use my guide wire to advance a little further, and I'm going to advance my sheath just a touch beyond that intrapedicular zone. So the question is, how far do you go? And the best consensus, if you read some of the evidence, is that as long as you stay within the first 1/3 of the transverse process, that's a pretty good distance for you to park your electrodes. So I'm going to basically swap the guide wire with the lead. Going to hold this. This extension, which we all see on the sheet, is basically serves more as a clock indicator for me. So if I have to move this lead 12 o'clock, I'm going to position this. I think the camera is the other way around, but I position the extension 12 o'clock. If I want to go 3 o'clock, it'll go 3 o'clock. Otherwise, 9 o'clock, 6 o'clock. So in a sense, I can use this sheet to basically aid the delivery of the electrodes in whichever direction I want. So those are my leads there. And so what I'm going to do is basically the first position is the two middle contacts on that lead. They are basically right below the inferior pole of the pedicle. And the reason is because the middle two electrodes rests on top of the DRG. So your rep can essentially bounce electricity off the first or the fourth or the second or the third and can modulate that DRG, which is your target DRG. So once you have parked your electrodes, you want to basically move the needle so that the black mark on the Tuhi needle faces 12 o'clock towards the head. You want to hold on to the extension. And I always say the job of the driver is to basically carry your lead wherever you want to. But once the job of the driver is done, the driver needs to come back to the parking spot. So where is the parking spot? The parking spot is the bevel of the needle. So I'm going to hold, stabilize my lead, and I'm going to gently pull the sheath, and you can see the sheath coming back. And I'm going to keep a positive pressure there on the contacts so that the leads doesn't move too further out, nor does it get sucked in. And as soon as my sheath, which is that radio-opaque black ring you see coming close to the spinous process, I know that this is the time I'm going to form stabilizing loops for my contact. So I turn everything 12 o'clock. By everything, I mean the needle and the lead are basically, the needle and the sheath are married to each other. So if the Tuhi needle faces 12 o'clock, the sheath also has to face 12 o'clock. You can look here. And then I'm going to basically push the lead in so that I can get my top loop. How high do we go? The general consensus is if you go to the superior end plate or the disc level, that's a pretty decent height of the top loop or the superior loop, which is required to stabilize it. Now remember, the job of the driver is done, so I'm going to get the driver back in the parking spot. My top loop is undisturbed. My contacts, I'm happy with them. Now I'm going to move everything to somewhere around 4 o'clock or so. You can see that. So I'm going to use the driver or the sheath to aid in formation of the bottom loop, and I'm going to hold it there. Now, the job of the driver is done, so the driver needs to come to the parking spot. So I'm holding the lead while I'm pulling back the driver. The driver comes back to the parking spot. Now, we did the top loop, we did the bottom loop, but that's not enough. In order to balance the force of the vector, which are acting on the top and the bottom loop, I need to form a secondary small loop so that I complete the S-curve of my stabilizing loops. So I turn everything back to something around 10 o'clock, and I use my driver to my advantage. I'm going to use my driver to drive up the lead. How high should I go up? The secondary loop usually goes up to the height of the spinous process you see on that X-ray. And I'm going to, again, the job of the driver is done. So the driver basically comes back, and I stabilize the lead, and your case is done. So I think a lot of this is basically following the steps very ritually, so that you don't go wrong. The problem is if you actually make a mistake in step number 2, you don't realize that until step number 10, where you have to take everything out and do all over again. Now, we can do a lateral X-ray right now. For people who are starting off, I recommend doing a lateral X-ray a little bit earlier on when you have first sparked the contacts, so that you can get an idea that are you crossing the anterior border or the posterior border of the vertebral body, which is a ventral placement of the lead. So let's do a lateral, Steve, and then have a look at the contacts. Ramo, back to you.
Yeah, beautiful work. That was wonderful. Any questions so far before we take that lateral? Yes.
So far, the indication for the dorsal column. So far, the indication for the dorsal column and the dorsal root ganglion stem. How you suss out which patient is a good candidate for the dorsal root and not dorsal column?
Well, there's a Venn diagram. They're not the same. So you have a lot of different indications for dorsal column stimulation, quite frankly, based on our studies, including spinal stenosis, lumbar radiculopathy, post-laminectomy pain syndrome, i.e. failed back surgical syndrome, and then the sympathetically maintained conditions like you're mentioning, CRPS, causalgia. DRG stimulation, it's really the sympathetically maintained conditions, CRPS, causalgia. There are other conditions, as I mentioned, like peripheral neuropathy, that are not well addressed with dorsal column stimulation that are addressed well with DRG stimulation. So they're not the same, but they share. There's a Venn diagram. I have a slide I can show you that shows you those indications. The shared space between the two is really in the sympathetically maintained, the CRPS, right? The Kamler article in the New England Journal of Medicine, year 2001, was how we got spinal cord stimulation approved and covered by our insurance companies because it proved that it worked in CRPS. But the Accurate trial, which published in 2017 out of Pain, proved that 90% of patients basically saw at least a 50% reduction in pain, and that the cure rate was about 30%. Correct me if I'm wrong, Pankaj. But the high responder rate was significant. So if you're going to have a patient with CRPS or sympathetically maintained symptoms and you're debating between the two, there's no contest. Always go with DRG stimulation as long as the anatomy enables it. So if they have severe spinal stenosis at the level you want to go at, that's probably not a good situation. You may have to do spinal cord stimulation. Or if you're dealing with an arm issue and you want to do a C5 DRG, that might be a little risky, starting off. That's off-label, in which case you'd probably choose dorsal column or spinal cord stimulation. Yes, another question.
Do these patients undergo a trial protocol the same way SCS does?
Yes. So, yes, that's the simple answer. To a trial, and then you can proceed as long as they have a 50% reduction. Yes, Ed.
How do you pick between PNS and DRG for limb issues or peripheral neuropathy? And then secondly, do you consider foraminal stenosis before doing this procedure?
Absolutely. So always good to look at your perineural fat on a parasagittal T1 sequence on your MRI to look how much space there is. If there's severe neuroforaminal stenosis, you may consider that challenging, but not a contraindication. You may just let the patient know, hey, this may be more challenging. And if that occurs, you can always go to a level above or below because of the convergence divergence of DRG. Between PNS and DRG, that's a great question. If I have an indication that works between the two, DRG stimulation generally gets you to that high responder rate, at least an 80% reduction in pain, whereas PNS may work, but it may have a lower threshold, like 50%. So between the two, I'm going to go with DRG. But the challenge is when you're talking to a patient who had a knee arthroplasty and has severe pain from that, and you tell them, hey, I can put these wires in your spine versus I can put these wires next to your knee. They just had a surgery that screwed them up. They don't want you doing a surgery on their back because they're worried that that's going to get screwed up too. So I find a lot of patients are more interested in PNS because it makes more sense to them. That's where my pain is. That's where I want the wires. But if they ask me what do I think is best, what's going to give them the best chance of success, it's DRG. And then, of course, there's the coverage issues. So PNS is not covered by most commercial payers, whereas DRG generally is. Pankaj, how was your lateral?
Let's look at it.
It's so beautiful.
So that's the Cheerios Rama was describing. I think the key is Rama mentioned that as long as you don't cross the posterior border of the vertebral body, that's defined as dorsality in the foraminal space versus the usual dorsality we are used to where the leads are snug, completely posterior in the epidural canal. So you have nice loops. You have the Cheerios turning back, taking the shape of that bony wall of that foraminal cave. And, the L4 DRG has been modulated.
Well done. That was fantastic placement, better than me. Thank you, Pankaj. And all right, everybody. So thank you. That was a DRG session. We will open up to any questions out there during lunch, and then Doug's going to give a talk. If you could, please put on.